ഇപ്പൊ കേൾക്കുന്നുണ്ടോ? കേൾക്കുന്നുണ്ടല്ലേ? ഇപ്പൊ കേൾക്കുന്നുണ്ടോ? ഇപ്പൊ ക്ലിയർ അല്ലേ? ഓഡിയോ ക്ലിയർ അല്ലേ? നിങ്ങൾ ക്ലാരിറ്റിയിലില്ലേ? ഓക്കെ. ഇപ്പം ക്ലിയർ ആയിട്ട് കേൾക്കുന്നുണ്ടല്ലോ അല്ലെ? All right. So we were discussing on composites. We'll be discussing introduction, definition, history, uses, classification, and composition of composites. So composites are basically resin in three-dimensional composition of two or more chemically different materials with a distinct interface between them. In combination, the properties are superior to those of individual components of the composite. So evolution of the composite has started from 1955, and we can see that it is ever evolving. We have posterior bulk fill composites. We have light cured composites in the process. Initially, it was chemical cured composites. Then we have nanofill composites, and we have in 2005 we have a silurane composites, which was introduced by Weinman. So its indications are in class 1, 2, 3, 4, 5, and 6 restorations. It can be used as foundation or for core buildup, sealant and preventive resin restorations, aesthetic enhancement. It can be used in aesthetic enhancement procedures. It can be used for luting, luting of veneers, crowns, etc. It can be used as a temporary restorative material and in periodontal splinting. Its contraindications are in its inability to isolate the site. It is very sensitive to moisture. It is technique sensitive. Excess masticatory force can cause fracture of the restoration. Restorations extending to the root surface. Since the hybridized dentin is not etchable as the normal enamel and dentin, there can be gap between the restorative material and the root, and other operative errors. Advantages: it is aesthetic. It requires only conservative tooth preparation. It is insulative in nature. It is bonded to the tooth structure, and it's easily repairable. Disadvantages are that it may result in gap formation when restoration extends to the root surface. It is technique sensitive, expensive, and may exhibit more occlusal wear in areas with high stresses. High linear coefficient of thermal expansion is another disadvantage. Composite restorative material may be used as anterior aesthetic restorative material, and it can also be used posteriorly for restorative purposes. It is used as a veneer material. A complete veneering can be done with direct composite or indirect composites. Build up pores, cementation of orthodontic brackets, Maryland bridges, ceramic crown inlays, onlays, and laminates. It can be used as a pit and fissure sealant, and it can also be used repair of chipped porcelain restoration. Somebody's mic is on. Please unmute. Please mute it. Now we'll be discussing about the classification based on polymerization method. There is self-cured, light cured, UV cured, visible light cured, and dual light cured. That is, dual cured is light cured plus chemical cured. According to Anuservice, that is based on filler particles, it is classified as conventional, small particle, microfilled, hybrid. And according to Marsuk, it is classified into generations. Based on radio opacity, there is radio opaque and non-radio opaque composite. Based on mode of supply, there is two paste system, single paste and liquid chemically cured. Single paste system supplied in syringes, which is light activated disposable capsules like conformers. According to Graham, there is type 1 microfilled, type 2 is macrofilled, type 2 microfilled, and type 3 hybrid composite. Based on viscosity, they can be broadly classified into flowable, medium viscosity, and packable. Packable is mostly used in posterior, flowable is ideal for class 5 restorations, and medium viscosity composites are the one which is normally used for anterior restorations and all. Classification based on area used, there is anterior composite and posterior composite. Classification according to the filler particle size, which can be classified into megafill, macrofill, medifill, minifill, microfill, and nanofill. So basically, discussing on the composition of composite, it basically has a resin matrix, an inorganic filler, and a coupling agent. Resin matrix consists of the monomers, initiator, inhibitor, and pigment, and the inorganic filler consists of glass, quartz, colloidal silica. Coupling agent is the material which binds between the resin matrix and inorganic fillers. Mic mute you, please. BIS-GMA. Now we'll talk about the components of the resin matrix. BIS-GMA resin is the base for composite. Diluents are added to increase flow and handling characteristics or to provide cross-linking for improved strength. Common examples are like the resin material used as BIS-GMA, bisphenol, glycidyl methacrylate, and then UDMA, urethane dimethacrylate. Cross-linking agents and diluents use TECDMA and EGDMA. Fillers are basically silica particles, quartz, glass, etc. If the composite is made up of resin matrix and fillers, it is called filled resin. We have unfilled resins as well. Our bonding agent is an example of an unfilled resin because it just contains the resin part of it. It helps in bonding. So the filler particle is not necessary in it. So benefits of filler, it reinforces the matrix resin, resulting in increased hardness, strength, and decreased wear. Reduction in polymerization shrinkage, reduction in thermal expansion and contraction. It improves workability by increasing the viscosity, reduction in water absorption, softening and staining, increased radio opacity. Types of fillers used: ground, quartz, colloidal silica, and glass are the main type of fillers used. Coupling agent is what binds the resin matrix to the fillers. So chemical, it transfers the stress between all the materials and keeps them in a single phase. Organosilane is the bifunctional molecule which binds the filler to the resin matrix. So it has a sideoxane and a methacrylate end, where the sideoxane end bonds to the hydroxyl group on fillers and the methacrylate end polymerizes with resin. Inhibitors prevent spontaneous polymer formation. That is, we don't need unnecessary polymerization while storage or while placing the material. It can happen due to heat and light. It extends the shelf life, and butylated hydroxytoluene is the common inhibitor used. Pigments and UV absorbance. Pigments help in characterization and in shade selection. Metal oxides provide shading and opacity. Titanium and aluminum oxide is a commonly used pigmenting agent. UV absorbers prevent discoloration, act like a sunscreen, and benzophenone is a commonly used UV absorbent. So it prevents unnecessary curing of the material due to light. So polymerization mechanism, basically there are two polymerization mechanisms, that is chemically activated and light activated. Visible light activated, invisible light activated camphorocyanol is the most common photoinitiator. It absorbs blue light from 400 to 500 nm range. Initiator reacts with amine activator, forms free radicals, and initiation and additional polymerization occurs. Chemically activated composite system, two-phase system is basically seen. There will be a base phase with benzoyl peroxide initiator and a catalyst phase with tertiary amine activator. In light activated composites, the advantage is that the earlier system consisted of UV light activated system. Its limitation is that limited penetration of light into the resin and lack of penetration through tooth structure. Then came the visible light activated system, where it is a single phase system. There is a photoinitiator camphorocyanol, as I explained earlier, and there is an amine accelerator that is diethyl aminoethyl methacrylate. And the types of lamps used for curing are LED lamps, QTH lamps, and back lamps and argon laser lamps. These lamps have evolved over time, and initially we had bulkier lamps which had lower penetration. Now we have LED lamps and QTS lamps and other high intensity lamps which are very specific. So LED lamps using a solid state electronic process, these light sources emit radiation only in the blue part of the visible spectrum between 440 and 480 nm. QTS lamps are quartz tungsten halide lamps, tungsten halide bulbs, which act in the work in the blue range from 400 to 500 nm. Then we have back lamps. Back lamps use xenon gas that is ionized to produce a plasma. It is plasma arc curing lamps. The high intensity white light is filtered to remove heat and to allow only blue light to be emitted, that is between 400 to 500 nm. Then we have argon laser lamps, which have high intensity and emit at a single wavelength. We know lasers emit only single wavelength, so it is very specific and used to emit a light at 490 nanometer. Then we have high intensity curing lights, which allows immediate curing, but its disadvantage is that it causes more shrinkage. It saves the chair time, especially in orthodontics. A high intensity curing lamp is more suitable than a low intensity curing lamp, because only the composite buttons need to be cured and fixed onto the teeth, and it has to be done very fast. However, high intensity short-term exposure time causes accelerated rate of curing, which leads to substantial residual stress buildup. Polymerization, we know the steps of polymerization, that is initiation, propagation, and termination. Initiation is the production of reactive free radicals, typically with light or restorative materials. Propagation is hundreds of monomer units polymerized to form a network mesh. 50 to 60% degree of conversion happens in this stage. And termination is where the unreacted material is trapped in this network and it forms one solid mesh. So degree of conversion is a measure of percentage of carbon double bond that have been converted to single bond to form polymeric resin. The higher the degree of conversion, the better the strength and wear resistance. Conversion value of 50 to 70% are achieved at room temperature for both type of curing systems, that is light cured and chemically cured. Polymerization shrinkage is one of the biggest issue of composite, that it causes residual stresses within the material. Composites exhibit shrinkage while hardening, more common when the restoration has extended into the root surface, resulting in gap formation. most important regarding the effect of polymerization shrinkage is the C factor. That is, C factor is the ratio between the bonded walls and unbonded walls. So what happens is when there are more number of bonded walls, the residual stress within the restoration increases. That is, the inward pull towards the restoration from its outer surface increases, which puts more pressure on the bond between the restorative material and the tooth surface, which can cause bonding failure. So we can see that in a class 4 restoration, it has a C factor of 0.25, which is the least. And in a class 2 restoration, C factor is 2. That is, the ratio of bonded to unbonded surface is comparatively less. And in a class 1 restoration, the C factor is 5, which is the highest. So to eliminate C factor, we have various techniques, out of which one is incremental layering technique. That is, we do incremental buildup of the composite material. Composite is layered as small increments so that the residual stress do not pull it towards the center. So we have better bonding and adhesive failure does not occur. So we have conventional or traditional microfill composite, which is its composition is ground quartz mostly, uh, most commonly used filler. Average size is 8 to 12 micrometer. Filler loading is 70 to 80% weight, which is 50 to 60 volume percentage. Its properties are 250 to 300 megapascal compressive strength. Its tensile strength is 50 to 65 megapascal. Elastic modulus 18 to 15 GPa, and hardness is 55 kHn. And coefficient of thermal expansion is with higher filler resin. The coefficient of thermal expansion is significantly reduced. Then we have microfill composite developed to overcome surface roughness of conventional composite. In conventional composite, due to the larger filler particle size, it is more rougher and it's more difficult to polish. Whereas microfill composites are easy to polish. Its composition is it has a smoother surface due to the incorporation of microfillers. Colloidal silica is used as microfiller, 200 to 300 times smaller than the average particle in traditional composite. Its properties are inferior physical and mechanical properties to those of traditional composite due to smaller filler particle size. 40 to 80% of the restorative material is made up of resin. Increased surface smoothness, area of proximal contact can be easily built with these composites. Its compressive strength is from 250 to 350 MPa, tensile strength 30 to 50 MPa, which is lowest among composites. Its hardness is 25 to 30 kHn. Thermal expansion coefficient is highest among composite resins. Small particle composite introduced in an attempt to have good surface smoothness and to improve physical and mechanical properties of conventional composites. Composition, small size fillers used, colloidal silica present in small amount, 5 weight percentage to adjust paste viscosity. Heavy metal glass ground quartz is also used. Filler content is 80 to 90 percentage. Its properties, due to high filler content, the best physical and mechanical properties are observed. Compressive strength is around 350 to 400 MPa. Tensile strength is around 75 to 90 MPa. Its hardness ranges from 50 to 60 kHn. Thermal expansion coefficient is twice that of tooth structure. Aesthetics, better surface smoothness than conventional because of small and highly packed fillers. Its radiopacity varies, like composite containing heavy metal glass as filler are radiopaque, which is an important property in restoration of posterior teeth. Hybrid composite developed in an effort to obtain even better surface smoothness than that provided by the small particle composite. Composition is two kinds of fillers: colloidal silica present in higher concentration, 10 to 28 percentage, heavy metal glass constituting 75 percentage, and the average particle size ranges between 0.4 to 1.0 micrometer. Its properties range between conventional and small particle, superior to microfill composites. Compressive strength is 300 to 350 MPa, tensile strength is 70 to 90 MPa, hardness is 50 to 60 kHm. Then we have flowable composites. Flowable composites have comparatively lower filler content. It is a modification of hybrid composite. Clinical consideration of class 1 restoration in gingival area, class 2 posterior restoration where access is difficult. It can be used as a pit and fissure sealant. It is ideal in class 5 restorations. Then we have packable composite market for posterior use, increase in viscosity, easier restoration of proximal contacts. One advantage of packable composite is that it has more curing depth. That is, it can be placed in bulk for curing. Packable composites have mechanical properties similar to hybrid composites. I will discuss on the steps of restoration. Now, initial steps in restoration is determining the shade, then isolation, etching, conditioning, washing or drying, bonding, and curing. Incremental buildup and curing of the composite, finishing and polishing. So initially what we have to do is shade selection. Shade selection has to be done in direct visible light. We should not do it under the dental chair's light, because dental chair light is more warm and it might interfere with the shade selection. Isolation is very important in composite for moisture control. Composite is highly technique sensitive material. Slight contamination or procedural error spoils the durability of the restoration. It may lead to bonding failure. Rubber dam is ideally used for isolation while using composites. Now, next step is etching or conditioning. Enamel and dentin has both needs to be etched and conditioned. For that, 37% phosphoric acid is used for the etching process. To cut into the enamel surface by the action of acid to produce micro porosities, which can be occupied by the resin for microtag formation. HN basically used is 32 to 37% phosphoric acid, in which 37% phosphoric acid is commonly used. It is available in liquid and gel form. Applying HN causes roughening of the surface by removing calcium from the enamel. Then after etching, it is washed and dried for 5 to 10 seconds. Etched enamel surface looks chalky white. Then bonding agent, which is unfilled resin, is applied. It forms an interlocking system. Then the bonding agent is applied to the conditioned tooth structure. After 20 seconds, it is lacquered and the matrix is placed. In class 2 cases, we have to build up the proximal and then then incremental layering of the main bulk composite is done. Incremental bulk buildup and curing of the composite is done following the initial buildup. Then finishing and polishing using tungsten carbide finishing burr is used to control the marginal ridge. Then rugby ball shaped fine diamond is used to control the occlusal anatomy. All high-speed instruments must be used with water spray. Then flexible abrasives can be used for the final polishing. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.